Hello and welcome to Direct Supply's Continuing Education webinar series. Direct Supply offers monthly webinars on a variety of topics throughout the year. The topic for today is the theory behind seating and posture. My name is Robin Malik and I will be facilitating today's meeting. This 60-minute webinar includes one nursing contact hour approved by the Florida Board of Nursing and one therapy contact hour approved by the Florida Board of Physical Therapy Practice, and one administrator CEU approved by the NAB. If you have questions during today's presentation, simply hover over the green bar at the top of the screen and use the chat feature to submit your question. Send it to me, Robin, the host. We will answer as many questions as possible at the end of the webinar. Please note, the information contained in this presentation is intended to provide general information, but not advice about certain regulations and initiatives. This is not intended as legal or other advice, and each situation may vary, depending on the particular facts and circumstances. You should not act upon this information without first consulting with qualified legal counsel. Today we are joined by Ellie Burcher. Ellie is an independent occupational therapist specializing within the complex sphere of specialist seating. As well as working as a clinical specialist in this area, she also works with Curtin as their ambassador for seating. This role involves working with Curtin on product development and providing a clinical aspect into this key area. Training clinicians across the United Kingdom is an important aspect in informing and supporting clinicians who work in seating. Ellie has developed an engaging training package for clinicians with all levels of seating knowledge to gain valuable theoretical background knowledge and up-to-date product information. And now, please welcome Ellie.
Hello, everybody. I am sitting over here in England, which is unsurprisingly raining, as it always does. And I'm going to talk you through our seating webinar, which is looking at the theory behind seating. What we're going to look at to start with is the principles of seating. So why are we providing our clients with seating? What is so important to provide them with seating for? One of the main reasons that we provide seating may be to relieve some pressure damage. Pressure damage puts a huge strain on our health services and can be caused incredibly easily. Clients can get pressure sores very quickly within 2 hours of sitting in a poor position. The difficulty with pressure damage is that it occurs subcutaneously, which means that it happens under the skin. This means that we're not always able to see the pressure damage until it's broken through the skin and is then even harder to treat. In addition, pressure damage can be caused anywhere on the body, so we have to be very careful. Originally, clinicians only considered perhaps the bottom and the sacrum and the thighs as a potential area for pressure damage. But as we know, we could get clients with pressure damage all across their body, on their feet and heels, shoulders, arms and elbows. So we do need to consider everywhere. As I said, it's not always immediately visible to spot a pressure sore developing, so we need to use other markers. The pictures at the bottom of your screen show a picture of blanching, of a red patch, and nurses often describe a sense of hollowness behind a pressure sore that's developing. The difficulty with this aspect is that we don't always know whether these marks are normal for our clients. We often don't see our clients very regularly. We're often very reliant on care teams to be able to tell us whether these marks have just been developed or whether they've always had a patch of red skin or discoloration. So it makes it very difficult for clinicians to determine what is a new pressure area and what is something that has always been there. So how does pressure damage get caused? One of the main areas in which pressure damage can be caused is when there is a force concentrated onto a small area. This is direct pressure, and as you can see there, it's when the bone is forced through the muscle onto a hard support surface. That could be a hard chair, it could be something in the chair that's put there incorrectly, such as a cushion that could be upside down or incorrectly placed. Could be other things that are left in the chair, for example, slings incorrectly left, or other things that people push down the sides of the chairs, like remote controls and all sorts of things. that can cause some serious damage to the skin quite quickly, as we said, within 2 hours. When we think about damage occurring within 2 hours, we need to consider that alongside perhaps the times that clients are receiving care calls. If a client is living in their own home and receiving carers to their home, it can often be far more than 2 hours before they are seen and repositioned, and that's a real concern for us to deal with seating. Another way that we get pressure damage caused on our clients is the friction and the shearing that we see in this picture. This is where layers of skin rub over each other and grate on the skin and make it very thin. This is often seen when we see clients who are sliding down the beds and the chairs, and they end up sort of balancing on the edge of the chairs. They're often positioned very well to start with, but then they slide over time with fatigue. We also see this sort of damage when we have manual handling issues, when people are taking in or removing slings and perhaps not doing it quite as smoothly as they should. Some slings are designed to stay in under a client, but some people may choose to remove those slings, and it's the insertion and the removal of those slings that can cause some serious damage to that skin by dragging it and pulling it across the skin surface. So how can we prevent pressure damage? There's many aspects that need to be put in place to help regulate and maintain skin integrity and reduce the development of any pressure damage. One of the key things is having knowledgeable and trained staff, so that people who are actually in there caring for the clients, being the caregivers, are aware of the markers to look for and aware of what to do if they spot a marker. It's also really important that we have access to appropriate support systems and products, and that is in a timely fashion. It's much harder to treat a pressure sore once it has become established and broken through the skin, so we often need to prevent pressure sores as a preventative issue, which can pose some problems getting those correct products in place. One of the key things to prevent pressure damage is regular position changes. As we've said several times already, within 2 hours that damage can be caused, so it's very important that we enable regular position changes so that somebody isn't sat in one position for longer than that 2 hours. And there's lots of things that chairs can do to actually assist the client and the caregiver to enable that to happen. So that's pressure, but what else do we provide chairs for? Well, we often think about posture when we're thinking about chairs, so we need to consider posture, and to understand what is going on with our client's posture, we need to understand what we consider to be normal posture. Okay. When we see a client that hasn't got normal posture, that has a development of some poor posture, it can be very restrictive, both physically and socially. In terms of poor head position, it can cause difficulties swallowing, difficulties breathing. It can also reduce your interaction. You often see clients sitting with their heads facing towards the floor. It's very difficult to interact when you're in that position, and we only know from sitting in a poor position for half an hour how painful that can be. It can cause clients significant pain if they're in those positions for long periods. It can also reduce the client's confidence if their independence, their ability to feed themselves, to breathe freely. That is going to have an impact on their confidence, their feeling of self-worth. And alongside that, if they're not able to hold their head to feed themselves properly, it's going to increase their dependence on carers, which again reduces the client's feelings of importance in their own abilities and their self-worth. So it does have huge impacts right across the sphere. So when we talk about normal sitting position, what are we talking about? Well, you'll see here with this lovely gentleman sitting in this fabulous chair here, he is sitting in what is considered, anatomically speaking, a normal sitting position. And what you can see there is the body considered in 4 sections. So there's the pelvis, the thorax, the head and the limbs. As you can see from the diagram, the gentleman is sitting with a beautiful 90-degree angle of his hips and his knees. He's got both his feet flat on the floor. His elbows and upper arms are vertical, his lower arms supported well by the chair. He's got a very straight back and his head is completely upright. Now, I can't see you all over in the US of A over there, but I'd really like you to all sit in that position just for a few minutes, get yourself into that perfect normal sitting position with a very straight back. I hope I can hear you all rustling to move to this position now. So really straight back with your head held high, with your legs, with your feet directly on the floor. Now this is what is considered a normal sitting position, and it's got all of the four sections of the body fully aligned there. I want you to stay sitting in that position for a few minutes while I just explain that on the list of the four bodily sections on your screen, the pelvis is actually at the top. This is because the pelvis, when we're considering seating, is actually the most important section of the body. If you get the pelvis supported and aligned correctly, you are a long way to getting the rest of the body supported. At times, the limbs and the head can actually mislead us slightly, and they can look aligned, and then they're actually not. And we're going to look at that a little bit later. Now, you've sat in that perfect posture for about 30 seconds, and I would wager that none of you are actually terribly comfortable, because whilst it's considered normal sitting, not really many people sit like that. Most of you will have had to have moved to get into that position, and some of you may have given up and already sat a bit more comfortably in your chair, possibly slumped down a little bit. And that's important for us to consider as clinicians and providers of equipment. Whilst we have this in our mind as an ideal, actually, is it comfortable for any length of time? So is it appropriate to force our clients to get into a position that isn't very comfortable for us and is unlikely to be comfortable for them? So it's really important to have this as an ideal, but not to stick to it too rigidly. Okay, I hope you're all now sitting back relaxed, you're not still sat in that perfect posture. Okay, postural abnormalities, they can be caused by lots of different changes in the body and can affect the body in a lot of different ways. One of the common ways that we see is musculoskeletal changes. So that's changes to the skeletal and muscular structure of the body, such as joint replacements, arthritic changes, breakages, or types of arthritis where the bone structure isn't as strong. We also see changes with neurological conditions, so where we see clients with perhaps having had a stroke, Parkinson's disease, things like that. We see different types of abnormalities. We also see some changes in posture and positioning with certain types of behaviour patterns. Anybody that works within a Alzheimer's or dementia unit will often describe a client to get into the fetal position. That's an incredibly common position to get into for that type of client group, but there's no known medical reason why they do that. It just seems to be developed from their actual behaviour that they get into those positions. Additionally, abnormalities can be caused by poor equipment, perhaps equipment that wasn't designed for the client or wasn't provided for that client. Care homes are always keen to reuse equipment wherever possible, but sometimes that equipment cannot fit the client and not be suitable for the client they're using it for and can cause some significant damage. We can also see abnormalities caused by poor care regimes where clients are left in poor positions for significant amounts of time or not getting the care that they require. We also see clients who are left in their beds for far too long and can develop some quite unusual abnormalities. It's very difficult to get to the bottom of how an abnormality is caused because it's often not just one of these factors. There can be lots of factors involved, so we need to consider those. So what we're going to do now is think about what types of postural abnormalities we often see in seating and how they present themselves. So I'm going to put up on the screen anterior tilt here. So the best way to feel how a postural abnormality is with a client is to actually try it yourself. So I'd like you all, if you can, to get into that perfect posture position that we started off with, a very straight back and feet perfectly planted on the floor, okay? And once you're in that position, I want you to try to get into this anterior tilt position. So this is where your pelvis is tilted very much forward, you get a very exaggerated lumbar curve. If you really exaggerate this movement, your shoulder blades will become retracted and your head will go up slightly. Okay, it's quite an uncomfortable position to be in. And what I want you to do is, when you're in that position, as you can see the lady in the picture there, she's not being supported much by the chair. There's very little of her body being supported by the chair, and also her shoulders are very far back behind her head. I want you, while you're in that position, to try now to reach forward to imagine taking a fork full of food. You will find that your upper limbs have become quite restricted and aren't as free to move because your shoulder blades are so retracted you possibly can't reach the table that you're sat in front of. You haven't got the range of movement in your shoulder and your upper arm. So just by moving your pelvis, you've actually completely altered what you're able to do. So in terms of independence, that might affect your ability to feed yourself. It might affect your ability to do simple tasks such as brushing your teeth, combing your hair, and all you've done is alter your pelvis slightly. So not a massive change in terms of your pelvis, but it's had a huge impact on the whole rest of your body. So now I want you to go back to that perfect position, the really upright position that we talked about, and then we're going to try the opposite, which is posterior tilt. So this is where you slump your pelvis slightly backwards. You will end up, as the lady has in the photo there, with very rounded shoulders. Okay, your head will naturally go down. You end up with quite a pronounced C-shaped spine in the upper spine there, and you will find that it's an instant feeling of quite grumpiness. It's a position that you struggle to be happy in this position because you can't see what's going on often. You're probably facing towards your feet. And this is a position we see quite a lot of clients in, sitting in poor chairs where they're not getting the correct amount of support. They end up slumping, which is very poor for your internal organs, as well as you can see in that picture. The lady, her abdomen is very squashed up, it's very folded, so that's not going to assist her in terms of digestion and processing her body very well. Okay, so what I want you to do is go back to that perfect position again, and then we're going to look at anterior tilt, pelvic obliquity, sorry. So this is where your pelvis is tilted to one side or the other. Okay, so if you push your pelvis very far down on one side, really heavily lean over to that one side, and that is called pelvic obliquity. It can happen to either side. Some clients twist to the left, some to the right. It's completely random what they seem to do. And what you will notice there is that the one side of your pelvis is very much further down, pushed into the cushion of your chair. And that will increase the pressure and the potential for sores on that side. So immediately you've got definitely more risk of getting pressure sores on that one side. The other thing that I want you to notice, if you can, is while you're sitting in that quite uncomfortable position, your spine is doing quite a strange S shape to try to realign your head and your shoulders. So it's very likely that your head and your shoulders will actually be quite level. And this is where, when we talk about the pelvis actually being the most important part of the body in seating, this is where our head and our shoulders can actually send us off track slightly. Because if I was to look at your head and your shoulders, it may look like you're sitting in quite a stable position and quite aligned, but actually your spine is doing quite a lot of movements to realign your head and your spine, and your pelvis is in a terrible position. So that is where we really need to focus on not just what the head and the shoulders and the upper body looks like. We need to try to establish where that postural abnormality is coming from. Okay. A couple of other postural abnormalities that we see is changes to the spine here, and you've got some pictures there to just demonstrate those a little bit. So the kyphosis is where you get a change in the upper spine curve, becomes quite pronounced. And as you can see there, it causes the clients to sit further forward in their chair, often because they get pushed further forward where they can't get into the cushion at the back of the chair. What you can also see there on the picture on the spine on the right is that the vertebrae are very protruded at the back, which can cause a significant risk for increased sores in those areas. Sores in those areas are incredibly difficult to treat because they have quite a limited blood flow, so they are quite difficult once they are present to actually resolve. And we also need to consider with clients who've got a kyphosis, a chair that's going to support and immerse them in a chair so it's more comfortable, so that it takes away the aspect of pushing them further forward in the chair. You will often find clients sitting with their bottom up against the back of the chair, but then their spine is actually quite far forward, and effectively their head is being pushed further forward in the chair. It's quite uncomfortable and can lead to some serious difficulties with transferring in and out of the chair as well. The bottom section there is called lordosis, which is where you get the excessive curve at the bottom of the spine. Again, you will see with clients will often pack their chairs with additional pillows and cushions behind this curve to try to get some support. The difficulty is with packing and filling that gap is that there is a tendency to overfill the hole, and you end up actually increasing and exaggerating the curve even further. So again, it's very important to make sure that you get the right amount of support, but not actually exacerbating or increasing those changes in their spine. The other one that we often see is scoliosis, which is the twisting of the spine. Now, this presents as very similar to the pelvic obliquity that we talked about in terms of the spine being in quite an S shape there. The spine has presented in the same way, but if you'll notice on the picture there on the right-hand side, the pelvis itself is completely stable. And so if you saw a client with this type of S-shaped spine, you need to determine whether it's the pelvis that is actually aligned or not, or whether it is actually the abnormality is within the spine by a scoliosis. There is varying trends to operate on a scoliosis to try and straighten the spine. This seems to go in phases and fashions, to be honest. I tend to see some clients who are quite routinely operated on, often as children, to try and straighten their scoliotic spine, but then other consultants don't seem to want to do a spinal surgery. So it does tend to depend a little bit where you live over here. I don't know whether that's the same over there. It certainly may well be. So you often get clients with a much more exaggerated curve than that one is showing. And what we need to do is, whilst we're trying to remember that ideal posture, we've got to also be very careful to not force a client into an uncomfortable position. If the scoliosis is fixed, then trying to force it back to a straight line is going to cause some significant pain to your client. So we do need to bear that in mind. Another postural abnormality that we see is windswept deformity. And this is, which I think hopefully you can see in the picture, this is where the legs are going off at an angle, often in a different direction to the upper body. This often occurs when clients have had a hip replacement and they haven't been mobilised fully after they've had that hip replacement, and it causes a weakening and a lessening of the muscles in that one side and can cause the tendons to tighten. The difficulty with sitting clients with windswept deformity is that they often are placed diagonally across a chair just to fit them in safely. The difficulty with that is they're often put in chairs that are far too big and wide for them, which then causes them to not get support from the back and the sides of the chair. They often then lean to try to reach the armrest, which causes a whole different type of change. As you can see in the picture to the left there, the lady is actually leaning quite heavily to try to get some support from the arm of the chair. So she's actually developed quite an unusual posture, because she's been put in a wider chair than she really needs. Okay. One of the other postural abnormalities that we see quite a lot is contractures. Now, these can occur in major joints. The picture that you can see there is of the gentleman's knees, but they can be caused in the upper limbs and in their hips as well. And this is where you get a tightening of the joints. This is where the joints tighten and can become very, very impossible to move. It's pulling the body up into a fetal position effectively. The difficulty with contractures is they are progressive and they can progress quite quickly in some clients. They don't always. Some clients can get contractures and can not develop any further, but other clients will develop quite fixed contractures quite quickly. What I mean by fixed contractures is when they are unable to be moved. So some contractures can be present, but with an amount of massage, relaxing, and perhaps a bit of physio work, they can actually be straightened out, those legs. They can come loose. You'll often see that with a client who's initially put in the chair, they have quite high tone in their legs, but over time, when they've relaxed, after about 10-15 minutes, their legs have actually dropped and their body has relaxed that tone. It's the same with contractures. They can be released slightly. If a contracture develops into a fixed contracture, they actually become almost like rock and they cannot be fixed. So when considering contractures, it's really important to identify with your client if they are fixed or whether they've still got some movement in. If they've still got some movement in the contractures, you could use seating to improve those contractures and try to maintain that movement at those joints. However, if you've got a client who's already got some fixed contractures and there's no movement at the joints, we need to think about seating supporting that position. We may not be able to improve it, but we may be able to support it so that they're not getting any worse. Okay, next one we're going to look at is foot drop, which is, as you can see from the pictures there, it's where the ankle joint goes into a strange position. If you remember in our very first perfect posture, the ankle joints were at 90 degrees to enable your feet to be placed firmly on the floor. Unfortunately, we then tend to see this foot drop often fixed into a downward position, into almost like a ballet toe position. It can be caused by lots of different things. We often see it in clients who have had a stroke, and we often see it in clients who've had Parkinson's disease. They can get foot drop quite easily. Also, you can see on the picture on the right there where a client's feet are very squashed down or almost flattened, and that can also occur when a client is in bed for a prolonged period of time. You and I, when we lie in our beds, don't keep our ankles at 90 degrees overnight, but with a client who's routinely left in bed for significant periods of time, that will become actually a normal position. When you add then the weight of blankets or duvets on top of the feet, it can actually push them down even further. Now, foot drop is often seen in clients, as I say, that have got Parkinson's disease or have a stroke, and they can often manage very well with these and it not hinder them too much, particularly when they're mobile, because they can often overcompensate by using their upper leg. However, when they become immobile, we really need to consider foot drop because it can become a huge problem. We need to ensure that the foot is always fully supported. It's an incredibly important feeling and sensation to have your feet fully supported. Again, I can't see you, but I would guess that most of you have got at least one of your feet on the ground, on the floor. It's very unusual for us to sit with both of our feet just dangling in the air. We tend to like the sensation of feeling grounded, of having an awareness of where we are in the world, and that's incredibly important from a sense of security. The other aspect is that you take a lot of weight and you take a lot of pressure through your feet, and if your feet aren't being supported, that pressure and that weight distribution the slack has to be taken up by other places in your body, which can increase the pressure and the weight bearing on other aspects. So supporting the feet is really, really important. Now, in the next session, we're going to have a look at those contractures and postural abnormalities again to look at how we can use seating to actually help us. So we're going to go on to the second half of the session now, which is, now we've considered the pressure and the postural issues and what can go wrong with posture, how do we actually address that with seating? How can we ensure that we get the right seating for our clients, and do we know what we want in our chairs to meet our clients' needs? Well, the first thing to consider is to think about what your chair is going to be used for. What are the goals of your seating? What are you trying to achieve? Is it to manage their posture, to support them? Is it to improve their posture? As we talked about there, If your client is in a very fixed position, it may be that you can't improve that. It may be that you will just be supporting them in that position to stop it getting any worse. If you've got to your client and been able to provide something before those postures have become fixed, you could be able to improve their positions. So it could be that you want a chair that's going to assist you in actually maximising those mobilities, maximising core strength and helping them improve. Is your chair needing to be mobile? Is it going to be helping them to manage their mobility? Is it going to be managing their fatigue? So, for example, if a client is an active full-time wheelchair user but becomes very tired and fatigued in the evening but doesn't want to go to bed very early, maybe a chair will help them to manage their fatigue in the evenings. Or is it for functional tasks such as independence with feeding? We've already seen earlier how important posture is in terms of enabling a client to be able to be independent with the simplest of tasks. So is it to give them some sort of independence? So once you've decided what your goals are in terms of clinicians, you do need to consider what your client's goals may be. They may be quite different to yours as clinicians or providers. The factors that are more important to clients may be what it looks like, maybe what colour it is, and whether it looks nice. So you do need to consider their views and their wishes and what they feel the chair is important for. Okay, so when we're starting to consider chairs, we need to start thinking about where it's going to be used. Is it going to be used in a hospital, domestic or care setting? So this might be thinking about the style of the chair. If you're trying to provide a chair within a domestic setting, your client may want it to look slightly more domestic so it doesn't stand out quite so much. If a chair is being provided in a hospital or care setting, you may need it to be slightly more robust because it'll perhaps be used for multiple users potentially. Think about the environment in terms of doorway width. If you want your client to be able to get into the chair in their bedroom and be moved through to a communal area, is your chair going to be too wide for the doorways? Do you need to consider a narrower option? Also think about the flooring types. Moving any chairs on carpets, whilst they are on many on wheels, if you've got a very deep carpet, that can be much harder to move them on. Many hospital and care settings now have kind of more lino-based, a plastic flooring type, which is much, much easier. Then you need to think about who's going to be using the chair. Can the client control the chairs themselves? Would a powered chair be most appropriate for them so that they can alter the position themselves? That gives a huge level of independence, which is fantastic for the client. It enables them to alter their position. However, if your client has some cognitive issues and doesn't understand or have some insight into their needs, or potentially wouldn't understand the controller and get themselves into some poor positions or possibly dangerous positions, is it wiser to have a manual chair that is actually operated by the carers or a family member? Or have you got something in between where actually a carer or family member can adjust the chair with the controls, perhaps their elderly couple looking after each other? So it's important to start thinking about those practical aspects of what you're going to need for your client. Okay, then we need to think about the type of chair functions that we're going to be thinking about here. So different chairs have different levels of movement, functionality and adjustability. So the most, I say basic, I don't mean that to be derogatory, but it's kind of a continuum. So if we start at one end, we have the single motor chair, and this is where, as the name suggests, there's just the one motor which links the backrest and the leg rest. Okay, so as you put the leg rest, as you put the feet up, the backrest will recline. This means you have a very limited choice on your position because as you keep putting the legs up, the back will go further back. So it doesn't enable the client to produce a very different position because it is just the one motor. In addition, if a client reclines quite significantly far back, it can encourage them to slide down the chair, which, as we said earlier, can put them at risk of that friction and shearing pressure damage if a client slides down the chair. Then we move on to the dual motor chair, which obviously, as the name suggests, has two motors. So one powers the backrest and one powers the feet and leg rest. This does enable you to have a little bit more positioning ability, because a client may want to have their feet up fairly high, possibly because it's more comfortable, possibly to support drainage of edema from their legs, but they may not want the backrest to be fully reclined. So a dual motor does enable them to be a little bit more in control of the different positions that they can get themselves into. As we said there, the back recline is really important. It's a very important function, and it's where it allows you to increase the angle. So if you sit upright in your chairs, another little test for you, if you sit upright in your chairs in that perfect posture, and you leave your lower legs exactly where they are and just bend your back backwards, it will increase that hip angle. Now that is a very important function for some clients, particularly those who require increased chest or abdominal capacity. So for example, if a client has difficulties breathing, they may find that slightly reclined posture opens up their chest cavity and enables them to breathe a little bit freer. Additionally, if you've got a client who perhaps has a particularly big abdomen, or if they have perhaps a tube feed into their stomach, they need to open up that abdominal cavity as well. So the back recline can really be a useful function in those chairs. It also shows you there a tilt in space. It talks about tilt in space. Now, as you can see in the picture, this is a function which is incredibly important in supporting a client's posture. We've talked already about how important changing position. Do you remember we talked about regular changes of position to redistribute where that weight-bearing points are across the body to help control the pressure areas so that they're not statically sitting on one or two pressure points over the day. So this tilt in space function tilts the chair back, but it maintains the hip and knee angle. So this is really critical for a client who perhaps doesn't have a lot of flexion at their hips or flexion at their knees. You've got them into a great position and you don't want them to sit statically in that position. The chair, as you can see in the picture, actually tilts back, but it maintains their position. Okay, so when the chair is upright, you've obviously got more weight going through their feet, you've got some going through the back of their legs, and you've got a lot going through their sacrum, and some going through the back of the chair. As you can see there with the faded picture, the chair actually tilts, and you can imagine there that you've got then more pressure and weight distribution going through the head, the neck, the spine, less going through the sacrum and upper thighs, more being taken by the leg rest and still some being taken by the footrest. So you've changed all of the weight bearing just by tilting the chair rather than actually having to alter any positions at their hips or their knees. So that can be excellent in maintaining a client's pressure as well as their comfort. Okay? So one of the things we need to do is make sure that we get our clients in the right sized chair. This is a bit important really, because a client in a chair that is too big or indeed too small can be as damaging as being in an incorrect chair. So it is really important to measure clients carefully as well as sensitively, bearing in mind we're measuring them at critical points of the body and getting often quite up close and personal. So you have to be accurate within the limits of how and where you are measuring a client. For example, if you're measuring a client in their bed, it can be a little more difficult, and it can be difficult to always get fully up close and personal to your client, particularly if they're in a big armchair or got a lot of blankets or clothing on them. It's important to remember that chairs generally come in standard sizes, but a lot of them can be adjusted in terms of width and depth, and we'll talk about that a little bit more. In addition, some more complex chairs can actually have height and elbow height adjustments. So we're just going to have a look at where is important to measure your client. So you've got a diagram in front of you which gives you 5 key areas that you need to measure. Now, in all honesty, it's the top 2 that are the most important in getting the chair right. So the seat width you can see there. Now, on this diagram, they've helpfully got on the diagram on the right that you actually measure the client from the back, which in a perfect world is the best way to measure a client. However, we know that we can't always access that aspect of the client. Sometimes it could be that they're sitting in a chair that we can't get to the back of, and they perhaps haven't got the sitting ability to sit on a plinth or the side of the bed to enable us to measure them from the back. So we have to sometimes measure the client from the front. The previous anatomical way of measuring was actually to find the ischial tuberosities on the pelvis and measure. But we need to be realistic in that our client group, and I can say this because you can't see me, but I have wide hips and a large bottom, and I'd like all of it to fit in my chair, really. So it's important that we be realistic when we're measuring our client and ensure that we've got the full width of the client's hips, including any fleshy bits, so that we really make sure that they're very comfortable in the chair. The next measurement that you can see, measurement B there, is the seat depth. Now this is very important. It goes from the back of their back to the under their knee. Okay, and this is to determine the length of the seat. Again, very important. We don't want a seat depth that is too long and pushes in behind the client's back of the knee, because that can cause some serious pressure sores underneath that knee. Equally, we don't want the chair to be too short, so that it's not supporting the full length of the upper leg. Okay, so we do need to get that about right. I'm just going to flick on to the next slide for you for a moment, because when we measure a client, we measure the actual measurement, but then we have to adjust it for seat width and for seat depth. We don't want the chair to be the same width as a client's hips, because that could potentially cause some shearing as they're getting in and out of the chair. And we have to be realistic in that clients may put on or lose a little bit of weight. So when we've measured the actual measurement, we want to add 1 or 2 inches to that to get the ideal seat width. In addition, with seat depth, we want to measure from the back of the bottom to underneath the client's knee, and then we want to minus 1 or 2 inches so that the chair does not come up right behind the back of the knee. If you can just feel at the back of your knee and move your lower legs while you've got your fingers on the back of your knee, you should be able to feel a large ligament that is joined to your knee joint. That ligament can get rubbed very easily by a chair that is too long in the seat depth and can cause a significant sore, which is why we want to just move the seat depth back slightly from that point. So that's why we take off 1 inch or 2. Okay, so just going back to seat height, we measure that from the floor to the back of the knee. Again, most of the chairs do not come with that adjustable, but all of the chairs come with foot plates which you can move up to meet the client's feet. Again, we talked about how important getting those feet supported are. Some chairs do come with seat height adjustability, which can be very useful if you've got a client who's still standing and transferring, because they need to be able to get their feet on the floor. What we can also see there is back height. Now, back height, again, is something that is only generally adjustable on the most complex of chairs, because it tends to be in a ratio with the size of the overall chair frame. So we don't tend to need to measure that too often. And the last measurement there is elbow height. Again, elbows are incredibly important. If you've sat for a long period of time on a chair that's got no elbow support, you soon find yourself needing to lean or to try to get some side support. So elbows are incredibly important. On most chairs, these are fixed at a fairly standard height, but on some of the more complex chairs, they are adjustable. That can be very useful for a client who has a scoliotic fixed position. If you imagine that S-shaped position in the spine, you will notice that one of your elbows is a lot higher than the other. So if that was a position that was fixed, we may want to actually raise one of the armrests up to make sure that they're fully supported. We don't want to push them back the other way. So once we've measured our clients and we've made the adjustments there to be very clear on what we want, it's very important to remember to clearly define whether the measurements you're providing are the actual measurements of your client or whether they're the measurements of the chair that you need. Okay, so that's quite important. Okay, so we've got the size of our chair. Now what else do we need on our chair? Well, this is where we start considering postural accessories. So they may or may not be needed. I think sometimes clinicians can be a little bit overawed with a chair that's got a lot of options and think it's better for their client. Some clients will benefit from a more basic chair with a good base. If you've got a client who has a complex changing condition, it may be a good idea to consider a chair that has got more options on it so that you can change the chair frequently to meet their needs. It's always very important with postural accessories to explain what their function is and the correct position to make sure that they're used correctly and maximise the benefit. And speaking as a clinician, I think sometimes we are poor at doing that. Because they're so obvious to us, we forget that actually it's not obvious what they're for and how they should be placed, and we need to ensure that we're educating carers and family members about what the accessories are for, how they're best used. So let's have a look at some postural accessories. Well, the first one we're going to look at is lateral support. So these are for clients who fall to the side, perhaps got poor trunk control, could be due to a stroke or a change in that way. Now you can see there on the two pictures at the bottom, the picture on your left is actually an integrated lateral support. That means it's attached to the chair. It's not in a fixed position. You can still move it up and down and in or out to provide the appropriate height and level of a support for your client, but it's actually fixed to the chair. The picture on your right is where the laterals can be added as an additional accessory. So it may be that the client didn't need those when they first had the chair, but they've developed postural lean, which you can then add on to. The benefit of having integral accessories is that carers and families don't take them off and they don't get lost. So that can be a real benefit, particularly if you're working within a care setting where bits often get mislaid. The important thing with lateral support is to remember that they can be fixed at different heights, okay? What I'd like you to do is sit in that pelvic obliquity position, the one where you had your pelvis very pushed down into one side and it created that S-shaped spine. Then using your hands, I want you to imagine that you've got two lateral supports on either side and you're trying to push your body, push your spine back into a straight line. Now, where you've got your hands as your lateral supports, you should notice that these are at different heights. They're not actually at the same height on either side. They will be slightly offset, okay? So it's a much better skill to have them slightly offset and at slightly different heights. But again, what we need to remember is when a carer or a family member looks at that, it's going to look very odd. So we need to explain why we've done that and why they're at different heights. You can also get leg laterals. If you have a client that hooks their legs over the side of the leg rest, which work in a very similar way, it helps to keep their legs on the actual leg rest themselves. The next thing we're going to have a look at is headrests, and these can be used for comfort or support, and again they can be integrated within the chair, or they can be as an accessory. You'll see there the picture top right, where the head support and the neck support is actually integrated within the design of the chair. And that is a specially designed headrest to support the shoulder girdle. You can see there the extent to which the headrest can move so that you can make it comfortable for the client. Some clients like to have their heads quite heavily supported. Other clients prefer to have less support on their head and neck. Very much down to personal preference and client comfort. The cushions at the bottom that you can see, there is just a couple of selections of different types of cushions that you can get. And the picture on the left there is where that's quite a complex headrest, which can be altered as and when you need it for different tasks. What you can see there on the picture on the left is that those wings can actually fold in and fold out, but they don't require tools. So if your client needed a significant amount of head support for certain tasks, such as feeding, you could actually push those wings round to create quite a significant high level of head support. But then when that task of feeding is finished, you could move those head supports away slightly to give the client less of a claustrophobic feeling, perhaps a little bit more opportunity to communicate and gain some head support and some head control independently. So there's lots of different headrests available. The key thing with headrests is to find out what's comfortable for your client. as I say, some clients like their heads to be quite heavily supported and quite tightly supported, whereas others would prefer a much looser type of support. And it's always worth considering whether you need one that can be used for different tasks and then taken out. So now we're going to look at the bottom of the chair, and we're looking at angled leg rests. Now these are really useful for two main client groups. One is a client group with fixed knee contractures. So where we talked about knee contractures earlier, they've got that tightness in their knees. That causes their feet to go further under the chair, and often what happens is they're difficult to sit in standard chairs. If you look at the picture on the left, it's quite a 90-degree angle at the knees required there. They may not be able to achieve that, and so if you look at the picture on the right, you can see that the leg rest actually tucks underneath the chair. That enables the client to have their contracture accommodated so that they can still get their feet on the foot plate, which you can see there is the purple bit at the bottom that actually flips down to support their feet. But it's actually enabling their knee contractures to be supported. If they're still got some flexion in those knees and that contracture isn't fixed entirely, it could be that once they've sat in the chair for 10 minutes, you move that leg rest a little bit more towards the original picture to try to improve and maintain some of that position in their knees. So you can use the chairs as part of a physio program to try and improve flexion. Okay. The other main client group that the negative angle leg rests work really well for is for clients who are still standing. Often when we tell clients to stand, we want to tuck their feet underneath their body to give them that strength and propulsion to stand. Well, the negative angle leg rest enables them to just tuck their feet slightly underneath them, which helps to give them that propulsion to stand up. So those can be very, very useful. The next thing we're going to look at is the foot plate. Now, we talked a lot about the importance of maintaining the feet and the ankle and making sure that they've got the sense of security and the feedback from their feet. And we talked also about clients who perhaps can't achieve that 90-degree at the foot plate there. You can see on the picture on the left that's a very 90-degree position, that they may not be able to achieve that with their ankle deformity. So the foot plate that you're looking at on your screen can actually be adjusted. So it can be the green section of it can be actually flattened down so that it will meet the client's angle of their ankle, so that it ensures that the feet are all fully supported, and it ensures that they're getting that feedback, that sense of security. What you can also see on the picture is, on the right-hand picture, you can see the bar with several holes going up. That enables that foot plate to be moved up or down, so that if you've got a client who can't reach down to that foot plate, if they've got short legs, you can actually bring the foot plate up to meet them. So it's really making sure that the chair is adjusted to fit them very, very well, and making sure that we get all of that support where we need it. Okay, when we're looking at postural accessories, we also need to consider harnesses and positioners, and that may be useful for clients who have involuntary movements and who perhaps have quite riding movements or strong extensor thrust. They can be very difficult, harnesses and positioners, and I don't know whether it's the same over with you, but over here in the UK, they are a bit of a grey area in terms of provision. There's often a concern about providing positioners and harnesses because of the safety and restraint issues. What I would say is don't dismiss them completely, because they can be incredibly useful for certain clients. It may enable a client to sit in a very supportive position for certain tasks, such as feeding, but you do have to always consider whether that client is being restrained. So I would say don't ever make the decision just simply on your own. Consider it with your wider team, because they may know something that you possibly don't about the client. Okay. Another postural accessory I just want to run you through is the tilt adjuster. We've talked a lot today about altering the position of the chair to redistribute that weight of the body across the chair, get the chair to do the work, redistribute where those pressure points are so that the pressure damage doesn't get caused. Well, we also talked about how a client that could use the chair control of themselves could have a powered chair and readjust their position. But what if you've got a client who can't alter the position themselves and they don't have a carer or a family member that can regularly alter their position within the chair? They may be in their own home alone waiting for care calls that could be 4 or 5 hours apart. That's going to be a serious issue for their weight bearing and managing their pressure and skin integrity. Well, the tilt adjuster actually replicates what the carer or the client would be able to do. So it actually repositions the tilt automatically. So if the client hasn't got ability to do it, it can actually enable them to do it. It moves the chair through the tilt angles automatically, and it does that by doing it, moves it by a very limited number of degrees over a 3-second cycle. Now what you can see there is in the picture, you can see how the chair is tilted back. And this, the chair will actually do that automatically over a 4 or an 8-hour period. But what I would say is that the movement is very gentle, it's very comfortable. It doesn't feel like you're being seasick or that you're suddenly jerking into a new position. It's much more gentle, subtle movement, okay? So it can enable the client to be positioned by the care team and then left in that chair. The chair will then replicate those movements. So over a 4-hour period, the client will move gently through the tilt positions that you can see there and back up again. Okay, so it will actually support that regular repositioning for the client if they couldn't do it themselves. In addition, what's important is if the carers then come back in, perhaps at lunchtime, and want to feed the client, they can override the position they're in. They don't need to wait for the chair to slowly come back up to an upright position, and they don't have to feed the client in a very reclined position. So the position can be overridden by the care team to get them to do the task they need to do. So it's an absolutely fantastic accessory for clients who wish to remain at home, but perhaps are on their own for long periods of time. It's a wonderful accessory. We're going to move on now to just thinking about what pressure products you could use. We've got 2 main types of pressure products, which is the reflection foam, which is, as the name suggests, it's a foam-based. It's the picture on the right there with the handprints in. And it's based on a memory foam type of a product, and it's very good for perhaps medium pressure relief. The one thing I would say about the foam is some clients can find the foam gets quite hot, it can warm up with body heat. And some clients who have temperature regulation issues can find it a little bit too warm. The picture in the middle of your screen there, the sort of honeycomb shape, is actually IntelliGel. And this is a gel-based pressure product. It's high to very high pressure relief, so it's incredibly good for clients who have very poor skin integrity and perhaps have a history of pressure issues. And that is a pressure cushion that, because it's gel-based, it's actually quite cool. It doesn't warm up with the body, so it retains a cool feeling. And that helps to regulate the client's body temperature. So that can be excellent if you've got a client who has got complex pressure issues. We also can use, in some chairs, drop-in cushions. So if your client is perhaps a full-time wheelchair user who has a contoured or specially personalised cushion that they particularly like and are very happy with and is working well, then rather than having a cushion in your chair, you could actually use that cushion and just drop it into the seat base. So that means that they're using a cushion that they perhaps trust and are happy with and works well, rather than trying to reinvent the wheel, you're actually using something. It's always very important that if you're using integrated pressure relief that you don't put thick fabric coverings over the seat, so that you're not reducing or deteriorating the effectiveness of the pressure cushion. A lot of the specialist chairs actually come with a special 4-way fabric that covers the client contact surfaces, so that's the footrest, the leg rest, the seat, the back of the chair, the headrest and the armrest. So anywhere that your client is going to come into contact with the chair is really great to have a special vapor permeable fabric on it, so that you're maintaining their pressure and skin integrity across all of those contact areas. Like we said right at the start, pressure sores can pop up anywhere, so it's very important that we make sure that the whole of the chair is safe for them to use. The pressure products are generally used just in the seat, just in the sacrum, but the rest of the chair and the client contact surfaces will have a level of pressure relief, often the foam base in them, so that you are still getting a level of pressure relief right across all of those contact surfaces. Okay. It's also very important that we consider reviewing our chairs. Clients change, as we know all too well. Sometimes, sadly, our clients do deteriorate, and sometimes they improve, and sometimes that will impact on their use or their needs within the chair. It could be that your client develops different postural changes. It could be that they have further medical changes. They may have a further stroke, which may change the need for different postural accessories. They might need to increase their postural accessories. In addition, they may change dimension. They may get bigger or they may get slightly smaller, and we need to ensure that the chair is able to still be appropriate for them, still be the correct size for them. And so we need to consider whether that chair can be reconfigured to still suit that client, or do they actually need a new chair. In addition, the chairs can get just damaged. They do get battered about a fair bit when they're used heavily in perhaps multi-user environments, hospitals and care homes. They can get used a lot, and they do often need, they can get damaged and they may need repair and refurbishment. And it's important that we enable people who have these chairs to contact the correct person to get whatever repairs or reconsiderations or new postural accessories. So that is the end of my session. So I'd like to open it up to Robin and any questions.
Yes, thank you, Ellie. We do have a few questions that were submitted already. If anyone else has questions, feel free to submit them via chat or the Q&A on the sidebar. The first one is, what is the technical term for the leg abductor pads on the picture of the purple Jerry chair? Are they available for standard wheelchairs?
Say that again, sorry, Robin. Which slide were you thinking of there? The purple chair?
The purple Jerry chair. They're wondering the technical term for the leg abductor pads and if those are available on the standard wheelchairs.
Yes, they're the leg laterals. The ones, I'm just trying to find I'll just flick back through and see if I can find do people mean this one, the laterals that can go on the sides of the legs? They are just called leg laterals. They look very similar to the picture on the right. They're slightly smaller in shape. They're slightly rounder, and they attach effectively to the footplate. If I flick on to where we looked at the footplate, they actually attach into those holes that I told you about. So they work in a very similar way, and they are called leg laterals, and they can fix onto a huge number of the chairs. So if you've got a client who likes to move their feet to the side and underneath the leg rest, that's obviously a poor position, and it can also damage their feet because they can get caught up in the workings of the chair. So they're called leg laterals.
All right, great. Okay. The next question is, do you measure the wheelchair depth differently for a patient with kyphosis or lordosis? I apologize if I said those wrong.
No, you're fine. You would still just measure the actual client's depth measurement from the back of their bottom. I'll just go back to that picture. You'd still measure it from exactly the same place, that measurement B, but what you would want to do is note in your notes whether there was a significant lordosis. So if they had a lordosis and that section where sort of E is, they had a big gap there, you might want to not measure any differently, but you might want to consider that. As I say, a lot of the chairs can be adjusted in terms of the depth on site slightly, and they are all designed to have lumbar support in them, so they will already have that. If you've got a client who has a significant lordosis, you may be looking at a slightly more complex chair which you could adjust the seat depth on site anyway, because depending on how exaggerated their lordosis was, you may need to adjust the seat depth accordingly. But at your initial assessment, I would say don't make an adjustment for that measurement. You'd want to try to make it, just do the measurement as you normally would and then match the chair to it.
All right. I'm going to do one more question, and then for any other questions, I'll send out answers afterwards, just because of timing. So the last question we'll do is, what can be used in the bed to avoid foot drop?
The important thing with foot drop, it's very difficult to avoid in a bed because just naturally when you're lying down, your feet they don't stay at 90 degrees. If you think when you're in bed tonight, you don't keep your feet at 90 degrees. So there are products available that they're foot blockers that can support the feet in 90 degrees, but what I would say is that's not terribly comfortable for overnight either. What's more important is to enable those clients to sit out more regularly. The clients that will develop foot drop in their bed are often left in bed for sometimes months. I will sometimes see clients who've not got out of bed in 8, 9 plus months. And so it's very difficult to limit it. It's more of a preventative measure, is to enable those clients to sit out in a supportive chair, supporting those feet at 90 degrees through the use of a foot plate so that they've still got that movement and that flexion in their ankle.
All right. Excellent. Thank you so much, Ellie. As a reminder for everyone who attended today, you will receive 1 complimentary administrator CEU approved by NAB, 1 nursing contact hour approved by the Florida Board of Nursing, or 1 therapy contact hour approved by the Florida Board of Physical Therapy. To receive your final certificate and contact hour credit, you must fill out the survey that will be sent to you in the next few days. This survey is given to gain your feedback on the webinar and also confirm that you attended the session. You'll have 1 week to complete the survey, and then you will receive your certificate of completion and credit within 2 weeks. And now, for anyone interested in learning about the seating and positioning products that Direct Supply offers, I would like to introduce Kelly Sullivan, our Senior Product Consultant.
Hello, my name is Kelly Sullivan, the Senior Product Consultant for Rehab. Today I'd like to talk through some of the Direct Supply's product solutions as it pertains to positioning solutions for you. The key to good positioning is good posture, which can be achieved by using equipment to encourage proper posture and midline alignment. As Ellie mentioned in her presentation, one must take a lot into consideration in order to provide the resident with the correct solution to their needs. For example, measurements are essential in equipment selection. Seat to floor height to ensure correct angle of leg positioning, armrest height to solve for lateral leaning, seat depth so circulation is not cut off behind the knees, and seat width to help correct lateral movement. Curtain chairs not only offer superior posture support and exceptional positioning, but outstanding comfort for the end user as well. We will explore their positioning chairs in the next few slides. The first curtain positioning chair I will be highlighting today is the Florian 2. This tilt and space chair is manually operated, yet is highly adjustable. The footplate can be flipped up when not in use, and the legs can be elevated. The lateral supports can be expanded to accommodate the resident's size or moved inward for additional trunk support. Transfers are made easy with removable arms as demonstrated on the insert image in the middle of the slide. There is also a 25-degree negative leg rest angle to help facilitate simpler transfers. The IntelliGel incorporated into the seat helps with pressure management. The honeycomb structure of the gel distributes weight evenly and allows for breathability, helping to reduce not only moisture buildup, but the propensity of shear stress and abrasion. The honeycomb column buckling design also allows the cushion to adjust to any body type. The Florian 2 offers an ergonomic molded backrest along with a headrest that can be adjusted to provide neck support when tilted in the chair. The push handle in the back is rounded so it's easier to grasp as well. All curtain chairs come standard with Dartex upholstery, which is breathable, helping to mitigate moisture buildup, and is extremely durable too. It can even be cleaned with bleach if need be. Dartex withstands rips or tears that can be problematic for other chairs in the market, for example, when a resident with cognitive impairment picks at the fabric. The next curtain chair we will look at today is the GE2 Tilt and Space chair that has some of the same properties as the Curtain Florian 2, meaning it comes with Dartex upholstery and IntelliGel incorporated into the seat. However, this chair offers an electronic operation for simple, effective positioning adjustments. The backrest provides effective postural support and a unique helical motion lateral support, adjusting for optimal trunk support. The leg rests also come with laterals. The chair can be customized to fit a resident shape with adjustable seat length and footboard height and angle. It is also extremely easy to use and ergonomic for the user since it can be operated electronically. The GE2 chair is an excellent solution for semi and non-ambulant users in a variety of environments. The Omega model has a robust frame with a deep angled seat, perfect for an individual suffering from spasticity as a result from a clinical condition such as Huntington's disease. It also comes with a pivoting seat at the front edge to retain knee to floor height. The horizontal and vertically sculpted back aids midline stability, and the chair is constructed as a modular system with back, arm, and seat components. The leg rests latch to the frame along with the side and is comprised of supportive reflection foam for superior comfort. The Omega chair is able to withstand demanding and severe movements, yet provide a safe and relaxed seated position. A sculpted back and contoured seat assures optimum comfort and provides good positioning for activities such as eating, while relaxing and sleeping is encouraged by the uniquely linked back and seat recline. As the back angles, the seat angle increases to guarantee a consistently good seated position without affecting the front seat height. The last product I would like to call attention to today is our brand new Panacea HTR chair, which I'm very pleased to introduce as our economic solution to positioning needs. This chair offers infinite adjustability along with tilt and recline functions. Other adjustments include width of removable lateral supports, footrest length, placement of headrest, elevating calf support, height of armrests, and detachable 20-inch wheels if ordered with this option. A lap tray is included and can be ordered with an optimal 3-pocket storage compartment that can be positioned in the back of the chair, which holds the tray. There are 4 upholstery colors to choose from that offer a more residential look and feel than the traditional recliner color options that you may already be familiar with, like jade or dusty rose. Color options on this chair include regimental blue, sand, espresso, and gunmetal. The Panacea HTR chair is a wonderful pressure redistributing, mobile tilt and recline chair at an affordable price point for you. Thank you so much for your time today. If you have any additional questions, please don't hesitate to contact me via email or my direct phone line here at the office.